Dr. Nirmal.
Thank you. May I able to share my screen, please? Yeah. Thank you very much. Greeting from India and Indian Academy of Neurology Epilepsy Foundation. So today I've been given the topic to speak on when to treat and with what doses. I'm sure there may be some overlap because we have a couple of lectures coming on the selection of drug and for initial treatment for adults as well as children. So it may be easy for me to make it simple to start with. So when I'm talking about when we are talking about the seizure, as Dr. Abdul Malik has explained to you, somehow that I was not able to, my camera got this thing, so that's fine. So when we have a patient who comes as a possible seizure in emergency room or the primary care provider, we need to look at these two things, whether could it be an epilepsy or not likely to be epilepsy. If it is an epilepsy, then is it a first seizure or a second seizure? And if it is a first seizure, is there a low risk for second seizure? Then we review the individual risk benefit. But if it is a high risk for second seizure, then we say probably we are dealing with an epilepsy and we start the treatment for an epilepsy with anti-seizure medication. But if it is not likely, then we look for the other causes, and I won't go into the detail of that. So for effective management, what patients should have we should have an individual care for each patient. And that is what is very important. So after a first unprovoked seizure, anti-epileptic drug therapy should be considered if the individual has a neurological deficit, EEG shows epileptic activities, brain imaging shows any structural damage, and the risk of having a further seizure is unacceptable. So AED treatment strategies should be tailored to the individual needs. Again, depending on seizure type, epilepsy syndrome, co-medication and comorbidities, the individual's lifestyle, preference of the individual, family and or carers, and all individuals with epilepsy should have agreed upon comprehensive care. So decision to treat is highly individualized, weighing the risk of treatment against the risk of seizure. That's what the Epilepsy Foundation of America says. So now when to start the medication? Decision of whether or not to start anti-seizure medication therapy in an unprovoked seizure in an adult depend on factors like recurrence, benefit of early versus deferred treatment, second unprovoked seizure, or acute symptomatic seizure. And American Academy of Neurology, American Epilepsy Society, all have on the management of unprovoked first seizure in adult advocate an individual approach that weighs the risk of seizure recurrence against adverse effect of anti-seizure medication. So when we go further into the management, there are several aims of the treatment. We need to reduce the risk for further seizure. We need to avoid the side effect, and we allow the patient to lead a lifestyle consistent with their capability. The non-pharmacological support can have an important role in epilepsy, and we need to look at that. And helping the patient to identify trigger can be helpful, and education and support for the family and the patient is also very important. There are various options for the treatment, and up to 70% of patients, you all are aware, would have their epilepsy controlled with single anti-epileptic drug. And for those epilepsy who do not respond to AED, there are other possible treatment options which are also available. And like the other treatment options are ketogenic diet, vagal nerve stimulation, and brain surgery, which I'm sure you are going to discuss in next lectures. There are various variety of anti-epileptic drug is available, and a broad range of anti-epileptic drug is currently available to treat the epilepsy. And individual AED are often available in a number of different formulations, and each AED has its own risk and benefit. And they can be categorized as first, second, and third line and third generation. We'll discuss about them. And they can also be characterized by their mechanism of action. So you look at the AEDs as I talked about first generation, second generation, third generation. The first anti-epileptic came phenobarbital, and I think before that was bromide, but we are not talking of that. Phenobarbital is still available, 1910. Then phenytoin, primidone, ethosuximide, valproate, carbamazepine, clobazam. So these were the first generation of drug. Then second generation started like oxcarbazepine, lamotrigine, gabapentin, topiramate, felbamate, tiagabine, and levetiracetam, jonissamide. And now in last 20 years, what we are talking about, third generation is phospheniton, rufinamide, lacosamide, reticabine, eslicarbazepine, parampanol, brivaracetam, stiripentol, cannabidiol, fenfluramine, and cenobamate. So many of these drugs may not be available in our country, particularly like fenfluramine and cenobamate is not available, and cannabidiol not available in India. I am not aware about what other drugs available in Pakistan. But there are certain features which are common in older anti-epileptic drugs. They have a narrow therapeutic range, higher levelity for adverse effect. That's the reason we are looking for newer and newer drugs. Drug-drug interaction. Compared to the older AED, newer agents often have a wide therapeutic range and fewer side effects. That's the reason we need to select the right anti-epileptic drug. So how we discuss right anti-epileptic drug? So what is the ideal anti-epileptic drug? So it is focused on the optimizing of the quality of life of patient. Thus the choice of AED has to look beyond only efficacy. So not only it should be efficacy, it should have safety and tolerability, its spectrum of activity should be high, and pharmacokinetic profile has to be absolutely without many risk of complication. So ideally, epilepsy treatment would lead to no seizure, no side effect, but can be difficult to achieve and require decision tailored for each individual. So there is no ideal anti-epileptic drug at the moment. But how do we strategize? We look at in countries in a subcontinent, we look at availability and costs first. Then we look at the patient's lifestyle, characteristic, preference, comorbidity, drug interaction, special population like pregnant women, elderly, learning disability, adolescent, hyperactive child, ease of use, epilepsy syndrome, seizure type. So we look at all these factors before we really look at the drug. And then we start that step for the AED selection. When to start treatment, when, as we already discussed, recurrent risk, seizure morbidity, risk of treatment. And then which medication to choose? We select the first AED should be guided primarily by evidence of efficacy for patient seizure type or syndrome. So what is it? Primary seizure, generalized seizure, focal seizure, or secondary generalized seizure? We select the drug as per the type of seizure. Correct dose is very important because you need to start low dose and go on to the appropriate dose before you say the failure of the drug. And then seizure recurrence. So if initial monotherapy fails, you could try another monotherapy and then subsequently look at the that the patient has not responded to monotherapy, then consider polytherapy, which will come at later point. So what are the various patterns of the response? With a single monotherapy for the treatment of newly diagnosed epilepsy, there are 4 possible outcomes. 1, 60% of patients will achieve long-term seizure freedom without intolerable side effect on a modest dose of single AED. Might achieve this with the second AED also. Around 15% of patients will experience additional relapse or period of relapse and remission. There will be 25% of patients who have refractory seizure right from the onset, will not respond to your single drug. And between these subset, there is a limited gray zone of patient, 5 to 10%, who will respond to combination therapy, which may be 2 or more. So this is what exactly is going to happen when we select any anti-epileptic drug for a given case. So if you look at the response to anti-epileptic, this is one of the studies which long-term outcome on 1,795 individuals who were newly diagnosed, treated for epilepsy and followed for 2 years. And among these, 1144 patients had been seizure-free. So 63% of the patient has been seizure-free between monotherapy and change of the drug. And the 36.7% were not seizure-free. And that's the situation which is from this large study has come. So most patients who attained the control of seizure did so with the first or second epileptic. And you can see that first, the 820 patient and the 71% achieved seizure freedom. And then second, another 18%. But then when they added third, fourth, fifth, sixth, seventh, the seizure freedom was not much. The probability of achieving seizure freedom diminishes substantially with each subsequent AED regime try. And then this is 1/3 of the patient epilepsy remained uncontrolled. And this is one of the 2018 paper in JAMA, which I am quoting. Now, there, as we already discussed about newer anti-epileptic drug, you could see that there are so many newer drugs has developed in beyond 2000, and that's why we call them as third generation or the newer drug. And what is the difference? They have a different mechanism of action, and compared to older anti-epileptic drugs, the trials demonstrated that they are equally effective as monotherapy or adjunctive therapy. But there is a favorable safety profile and fewer interaction with older anti-epileptic. So if you look at the impact of newer AED on overall outcome of patients with epilepsy, this is 2004. You could see that seizure freedom on combination therapy, on 2 anti-epileptic, on 3 anti-epileptic, not much. But you look at 2014, it's much, much better. So some patients with focal epilepsy might benefit from newer anti-epileptic drug as an adjunct therapy in the hope that they could acquire seizure free. So now monotherapy versus combination therapy. Ideally, monotherapy, monotherapy, monotherapy. But there is robust evidence is lacking and controversy continue over when and how AED should be combined rather than substituted. So these are some of the questions which are still remain, and we need to look at that. 2013, the ILAE published recommendation based on 64 RCTs and 11 meta-analysis on use of several AED as monotherapy. And there are adults with focal onset. You have level A evidence with carbamazepine, levetiracetam, phenytoin, and zonisamide. Children with focal onset, you have level A evidence with oxcarbazepine. Elderly patient with focal onset seizure, you have level A evidence with gabapentin, lamotrigine. Adults with generalized onset seizure, there is no evidence for level A, level B. Only with level C you have. Children with generalized tonic-clonic, you have no evidence for level A. Children with absence, again, level A is ethosuximide, valproate. Benign epilepsy, no evidence. And juvenile myoclonic epilepsy, again, A, B, C, none. Only D is topiramate and valproate. Similarly, AN practice guideline update, which is 2018, much later than levetiracetam. You have level B, B and C evidence, like lamotrigine is level B evidence. Lamotrigine again could be considered for, and gabapentin could be considered to decrease in patients with above age 60 years. Then again, level C, all these are level C to level U evidence. Level B, unless there are compelling reasons based on AE profile, ethosuximide or valproate uses should be considered before lamotrigine used to decrease seizure frequency. So that's the recommendation from the American Academy of Neurology. I just want to briefly speak about the SANAD study, which is recently published, AED monotherapy, unblinded randomized controlled trial in hospital-based outpatient clinic in the UK. They evaluated the effectiveness of AED monotherapy in focal and generalized. So this is partial seizure, more than 1,700 patients, and the generalized seizure, about 716, where valproate was considered, and here carbamazepine was considered. Just two, carbamazepine and valproate. So efficacy-wise, carbamazepine most likely to cause the treatment failure is gabapentin, topiramate. Tolerability, the least to the most likely to cause treatment failure, again, carbamazepine, topiramate. And effectiveness, time to treat failure for any reason from lowest to highest, lamotrigine at lowest, gabapentin, topiramate as highest. Similarly, efficacy, valproate was the most effective, lamotrigine was the least effective. Tolerability, again, lamotrigine was better tolerated than topiramate. Effectiveness, again, valproate was much better effective than other. Then effectiveness of monotherapy and combination therapy. Again, this was a cross-sectional survey, analyzed seizure control with monotherapy, combined therapy with two anti-epileptic drugs. 33% were seizure-free for monotherapy. Another 20% added with two AEDs. With more than two AEDs, only 4%, and not seizure-free was 43% out of 517%. So combination therapy can lead to seizure freedom in a considerable proportion of patients, so about 24% here. Seizure freedom and AES in monotherapy was a combination therapy. This was UK AED register, which was analyzed to study the effect and side effect of AEDs, control, monotherapy, and combination therapy. And what came out is tiredness, memory problem, difficulty in concentrating were the most common symptom in patient taking AEDs and were consistently higher in polytherapy than in monotherapy. Again, monotherapy versus polytherapy in children with epilepsy. This is polytherapy and monotherapy. The risk of adverse reaction was significantly lower in patients receiving monotherapy than the polytherapy. So 21% versus 16%. Combination therapy does not always mean increased effectiveness and side effect. So this is a prospective multicentric observational study, analyze the effect of alternate monotherapy versus combination therapy in children and adults with epilepsy whom first monotherapy failed. So patient randomized to alternate monotherapy. Again, 53% patient achieved the 12-month remission and 51% here. So treatment failure was about same 25, 27%, and mean retention was good, 454 and 447 days. And adverse reaction was seen again 46% versus 40%. And therefore, the results were almost in this study in children and adults was same. How to switch to combination therapy? So factor favoring switching to combination therapy, one drug treatment clearly beneficial, but incomplete seizure control on a maximally tolerated guide the physician when and how to combine anti-epileptic drug. There is a rational polytherapy, which is in the hypothesis, and this says that the concept is that combination with different mechanism of action are more effective than polytherapy with similar mechanism of action. And I'll come back to you with this. And although the evidence is scarce, some studies suggest that combination of drug that block voltage-dependent sodium is more likely to produce neurotoxic side effects such as dizziness, diplopia, and ataxia. Only the combination of lamotrigine and valproate has demonstrated synergistic effect. So here is a evidence which support the rationality of polytherapy with different mechanism of action. So these are sodium gated channel G plus G, and this is G plus SV2, the levetiracetam and brevitiracetam are the clear cut. G is gabapentin and SC is sodium channel. So if you combine GABA antagonist combination with SV2, it might be better, and you could see the responses a little bit better. Similarly, the sodium channel and the GABAergic, again, the responses are better in these patients. So what it suggests that combination of two different mechanisms of action would definitely have better rational, approach and lesser side effect, and that should be considered. With various combination, what can be tried? So drug 1, drug 2, these are the potential benefits. We already spoke about valproate and lamotrigine. The valproate ethosuximide, there are case series and observational study where shows some beneficial synergistic effect. Valproate carbamazepine, there are some anecdotal report. Phenytoin phenobarbital, anecdotal report. Vigabatrin tiagabine, there are some anecdotal report. Lamotrigine topiramate, some report. Lacosamide, levetiracetam, again some report, case study and observational studies. Valproate and levetiracetam, there are case reports. Valproate, clobazam and seripentol, there's controlled trials going on. And valproate, lamotrigine and benzodiazepine, there's some case study and observation studies. So guideline for combining AED, aspect to be considered when trying an additional AED include spectrum of efficacy, its adverse effect and profile, its expected effect based on the patient characteristic, and the possibility of pharmacokinetic and pharmacodynamic drug interaction which can require dosage adjustment. What do? I've got few more slides, that's all. 3 or 4 slides. Carbamazepine, clobazam, clonazepam, eslicarbazepine. So these are the drugs which can be tried, and these are the doses. Lacosamide is 100 to 400 milligram, lamotrigine 100 to 500 milligram, levetiracetam 500 to 3000 milligram, oxcarbazepine 600 to 2400 milligram, phenobarbital 60 to 180, phenytoin 300 to 600 milligram, valproate is 1000 to 2500 milligram, and genesamide is 300 to 500 milligram. The Neurology India paper, which has been published, has a clear-cut guideline for which seizure, what doses, and this is given milligram per kilogram, starting dose, maintenance dose, and maximum dose. It can be very useful by Dr. S.P. Singh, and it's published in 2017. And these are the guidelines for the pediatric patient. Again, carbamazepine, clonazepam, you could look at the doses, and they are also available in suspension form. So this was published in 2019 in Anti-Epileptic Drug in Pediatric Patient. So with that note, I come to my end. This is the program which will happen tomorrow. That's this is an AINA meeting where we are going to talk about the various epilepsies. Dr. Sanjay Singh, Prakash Kotekal, Chatabhuj Rathod, and Sita Jayalakshmi is going to be the speaker. And then the Epilepsy Foundation is organizing a program. Professor Gus Becker, Secretary General of IPE, is the chief guest. And we have various support group participating. Then I have started a special program which is called as Dimag Pe Charcha. It is a TV show. The first session was last month. So the second episode will be tomorrow on Monday, and where I'm going to discuss on epilepsy with Professor Sanjay Singh and Manmohan Mandirata. I'm sure many of you would be knowing him, a very famous neurologist from our country. And then Indian Academy of Neurology is organizing this awareness program where my secretary, Dr. Meshram, Meshram has been incidentally elected as trustee of WFN recently. And there will be panelists Sangeeta Rawat, Sita Chaturbuj, and Dinesh Naik. So thank you very much for your patient hearing. I'm sorry for a few minutes over time for the lecture.